Hello and greetings. I'm Dr. Vijay Bose from the Asian Orthopedic Institute from Chennai, India. This is part 2 of the series of talks which aims at simplifying and unifying alignment concepts in TKR. From the first talk, we now know that the unifying concept in alignment strategies is to adopt an FA philosophy and retain the CPAK type. The part 2 will cover how we achieve this with or without robotics. Now, it's important for you to have watched the part 1 video before you watch this one. Otherwise, you won't be able to follow the part 2. If you have not watched it earlier, all you have to do is to go to YouTube and type in Pocket Upgrade CPAK. This video of part 1 will come up. And once you finish watching the part 1, then you'll be able to follow the part 2. The goal today in 2025 is to optimize the three biomechanical dimensions of TKR, namely the alignment, the balance, and native morphology. If we give exclusive or overwhelming importance to only one of these factors, we call them respectively as mechanical alignment, kinematic alignment, or the gap balancing technique of buccal pass. However, if we want to give importance to all three, we call that as FA philosophy. If you combine that with retaining the same CPAK as it was preoperatively, then it's probably the best goal to strive for today in 2025. And this, of course, we call as FA philosophy and retaining CPAK type. The question is, how do we achieve this? The answer is very simple. It's robotics. So if you have robotics, then it's very straightforward to achieve this. Robotics has tools specifically to achieve this goal. In our institute, we have most of the gadgets that modern technology has to offer, and we have many kinds of robots. There's no doubt that the robots have improved our patient outcomes quite spectacularly. We have learned a lot from them, and our patients have certainly benefited a lot from these robots. So life is good. However, there are two things that worries us. The first thing is that technology is best when it brings people together. However, these modern gadgets seems to be dividing us rather than unifying us. We now talk about robotic versus non-robotic surgeons. This is not a healthy trend, especially when it's used for marketing purposes. When I say I have a robot and the surgeon down the road does not have a robot. So it seems to be creating a divide. And now we have those with robots, the haves, and those without robots, the have-nots. And this seems to be dividing us. And we are not very happy about this. The second thing is that technology cannot be an end in itself, but must aim at solving long-term problems. That's really the purpose of technology. So technology is a methodology and not the goal. So suppose we need to travel from Chennai to Mumbai. Traveling by air may be the fastest way to do that. However, traveling by air is not the goal. Traveling by air is only the methodology. So we must differentiate what is the goal and modality. However, now people seem to be mixing up both, which really does concern us. So in 2025, the time has come to unify things in TKR rather than divide in concepts and methodology. So with robotics, we can easily adopt an FA philosophy and retain the CPAK type in a very straightforward manner. However, if you look under the glamour and sheen of robotics, we find that robotics achieves this through three mechanisms. So if we break it down, the real advantage of robotics, it has got three main enabling tools. Number one, it enables the integration of anatomic parameters. Number two, it gives you a very accurate assessment of soft tissue balance. Number three, it allows you to modify your bone cuts to suit the balance. The question is, what if we develop the same three enabling tools outside of robotics? That's exactly what we have done. So we have developed three enabling tools that will achieve exactly the same goals as robotics without the need for robotics. And this we call as the factor methodology, which stands for functional alignment and CPAK type outside robotics. So with this, we hope to eliminate the divide between the haves and have-nots. So essentially what we have done is we have developed the three tools outside of robotics, which will achieve the same as what the robotics is able to achieve. The first tool is, of course, the Pocket Upgrade CPAK, which is covered extensively in the part 1 video. So using a valgus stress film, one can very easily, using the Pocket Upgrade CPAK, calculate the what CPAK the patient belongs to without the calculation of any angles. The second tool that we have developed is the CSB, or the coronal sleeve balancing blocks. So this comes in a blocks like this. And if you open the box, you will see spacer blocks with differential thickness. So this is the 15 series, you can see in brown color here. And the next tray has got the 16 series, which is pink in color. So all permutations and combinations of differential thickness is possible. You can calculate the coronal gap very accurately. The 17 series comes in white color. All possible combinations are seen there. The 18 series comes in black color. So with these blocks, we are able to accurately assess the differential gap on the medial and the lateral side. The companies usually give only one block, which is 1919, which is practically useless when you do the TCAD because it doesn't allow us to take any action based on what you measure. Now, there are some TCAD systems which have a composite gap of about 20 millimeters. So if you have a TCAD like that, then you will need to have blocks from 16 to 20, whereas we have a composite thickness like this example of 19, then you will need blocks from 15 to 19. The third thing that we have developed is a recutting tool that you need. So after you estimate the balance, you need to recut the tibia based on what your balance shows. And for this, we need a tool. The easiest tool that you can make is you can make extra holes in the standard tibial jig that you are using, like we have done. You can see that. So the third pin or the cross pin can be put again, and then we can take a recut based on what the balance shows us. We saw the three enabling tools. So with these three enabling tools, there are 6 simple steps, whether you use robotics or factor methodology, to achieve your goal of adopting a functional alignment and retaining the CPAK type. Now, these are the 6 simple steps. The first step is to have a patient-specific or personalized distal femoral angle. The second one is to get an initial neutral tibial cut, and then you assess the balance. The third step would be to do a functional recut of the tibia to achieve balance without doing any release. The fourth would be to find and incorporate a native femoral rotation. The fifth step would be to fine-tune the posterior slope of tibia to match flexion to extension, and this we call a space match. The sixth step would be, this is only in special situations, which we will cover, there may be a need for a soft tissue release, only in special situations. So we go to step number 1, where we do a patient-specific or a personalized distal femoral cut. It's very straightforward in robotics. If you have image-based robotics, then you have a CT scan, which tells you the native anatomy of the patient. Then you match your component to fit that native anatomy. If you have a non-image based robotics, then we do bone mapping or bone morphing, and the computer generates a model very close to the native anatomy. And initially you place your components based on this anatomy before you see what the soft tissue balance is. So it's very straightforward in robotics. We can achieve the same thing using the factor methodology with the pocket abridged CPAK. So with the pocket abridged CPAK, the femur can be divided into, in a non-valgus knee, into a valgoid femur, a neutral femur, or a varoid femur. And that's a very basic grid that we use. If it's a varoid femur, you have to cut the distal femur in 3 degrees. If it's a neutral femur, you must cut in 4 degrees. And if it's in valgoid femur, you must cut in 5 degrees. This is the basic grid. As you develop experience, you can probably expand this grid. But we strongly recommend, as you start off, you must stick only to this basic grid. So here's an example. It's the same patient I've shown here. We've taken a valgus disc film. Now we have drawn the joint line, and now we know that the joint line is obliquity is distal and significant, greater than 3 degrees. Therefore, it becomes a valgoid distal femur. So I need to cut this femur in 5 degrees of distal femoral cut or valgus. So it's as simple as that. So we achieve the same or incorporate the patient's native anatomy into what we are going to do. We know that the CPAK matrix has got 9 boxes. And from a very practical perspective, it's useful to divide them into 3 boxes of valgus knees and 6 boxes of non-valgus OA knees. Amongst the non-valgus OA knees, there are 3 common distal femoral morphologies, which are the valgoid distal femur, the median distal femur, and the varoid distal femur. This, of course, we make out based on the pocket abridged CPAK. Now, in the valgoid distal femur, there is significant distal obliquity either equal to or more than 3 degrees, which makes it a CPAK 2. In the medial distal femur, the distal obliquity is still present, but less than 3 degrees, making it a CPAK 1. In the varoid distal femur, the joint line is neutral, making it a CPAK 5. Now, these 3 constitute for more than 95% of the non-valgus OA knees that we see in day-to-day practice. Now, in the valgoid distal femur, As the joint line obliquity is equal to or more than 3 degrees, we have to cut it based at 5 degrees based on the grid. And that's what we have done. And we can see that we have reproduced the pre-op CPAK. In the medial distal femur, as the joint line distal obliquity is less than 3 degrees, we cut with 4 degrees of distal valgus and we are able to reproduce the pre-op CPAK. In the varoid distal femur, as the joint line is neutral, we cut at 3 degrees and here again we are able to reproduce the CPAK. So using this basic grid, we are able to incorporate the patient's native anatomy just like how a robot would do. Now, the incidence of a valgoid distal femur or a CPAK2 is 39% overall in the population, and in the incidence of a median distal femur or a CPAK1 is 26% overall, and the incidence of a varoid distal femur or a CPAK5 is 15% overall. Now we come to the 3 uncommon distal femoral morphologies amongst the 6 boxes of non-valgus ONEs. These are type 4, type 7, and type 8. As you can see, the incidence of them combined would be less than 5% and they're extremely rare. And therefore, these are sometimes referred to as the white tiger CPAKs. Now, these are not only rare, these are very dangerous as well. Now, how do we recognize this? We recognize this by the presence of an excessively bowed femur that you see on the long leg films or the scanogram. This may also have a proximal tibia with reverse obliquity or pointing downwards laterally. Now, these white tiger CPAKs have the following features. Some would consider them to be pathological anatomy and they must not be reproduced in your TKR. Following FA philosophy and CPAK retention may result in an unacceptable hip-knee ankle axis. It's best to cut the femur in 3 degrees of distal femoral angle and tibia in neutral 90 degrees and accept that in these rare distal femoral morphologies, one will have to do soft tissue releases. Those doing unrestricted KA without using CPAK likely to land up in problems with these white tiger dangerous CPAKs. They are reverse obliquity knees with JLO apex mostly proximal. So we move on to step number 2 now, which is to get a neutral tibial cut and have an assessment of the initial soft tissue balance. Again, robotics are able to do this in a very straightforward manner. All robotics have a system by which they display the medial space independently and the lateral space independently after you have placed the femur based on native parameters. We are able to do the same thing with the factor methodology as well. And in this video, we'll show you how we go about it. So this is a standard tibial jig that we all been using for years and years. So my initial aim is to cut the tibia at 90. And we typically would put the drop rod first and then we'll put the third cross pin. There's no point looking at the drop rod after you have fixed everything. So the third pin is going in now. And our initial aim is to cut 90. We always measure the lateral side to make sure that we have taken enough tibia. The first spacer block will be a 15-15 block. We will now be looking at the medial and the lateral space independently as the robot. So we now look at the medial space. And the way to hold the limb is in maximum extension with the minimum force using your fingers. I'm looking at the medial side and you can see that there's a little bit of laxity on the medial side. Therefore, the 15 is too small. So we need to move to the next spacer, which would be a 16-16 spacer. So after the 15-15 spacer, we are now going to put a 16-16 spacer and see what's the space on the medial side. The 16-16 spacer is going in. And now the medial side now looks very snug. However, the lateral side is still lax. So we need to move to the next spacer, which will be the 16 series now. So it will be a 16-17 spacer that we got to see next. So the 16-17 spacer, 16-17, we put that in and see what the lateral space is now. We know the medial is 16. So 16-17 spacer, we again see what the lateral space is. And you can find that there's still some laxity laterally. So I need to move on to the next block, which would be a 16-18 block. So I put a 16-18 block inside and see what the lateral space is. And here I'm holding the knee in full extension with the minimum force possible. And then I'm looking at the lateral side is still lax. So I need to go on to the next block, which would be a 16-19 block. So 16-19 block is here. And I'm putting that and seeing what the lateral space is. Now we find that both the spaces are snug. So 16 is snug on the medial side, lateral is snug with 19. So now we have accurately established what is the independent medial space and what is the independent lateral space. The medial is 16 and the lateral is 19. So we are able to do exactly the same thing as what the robotics is able to do. We now move on to step number 3, which would be to achieve a functional tibial recut of the tibia to achieve balance and thereby avoid any soft tissue release. This step is again very straightforward when you use robotics. Now, with the robotics, we now know what is the medial gap and the lateral gap. So we play around with the tibial cut so as to make sure that the gaps are equalized and we will not need any release. So this is very straightforward with robotic platforms. However, the same thing can be achieved with the factory methodology as well. So here we will leave the two pins that we use for initial 90-degree cut unchanged. We will just take out the third pin and then we will incorporate any varus and then we will reapply the third pin. The retaining the two pins is possible when you find that the restricted boundary that you use is within 3 degrees. So this is how we go about it, and we'll show you in this video. So here I got the two pins there. I've taken a 90-degree cut. Now I'm going to use a third pin. I now found that the space is 1619 as we showed in the earlier video. So I need to do something about the spaces. So I'm reapplying this same two pins, but now I'm pulling the drop rod into varus and reapplying the third pin through another hole, not using the hole that we used previously. So now we're using the saw and I'm just taking the medial side of the tibia. I will just plane out the middle. I will not touch the lateral side. It is so important that they use a jig to cut this, to do this step. Because if we use it freehand, you will find you will create undulations and your tibial platform tibial component will not sit properly. So it's absolutely critical that they use a jig. And I'm just taking the medial side. Now I'm reapplying the same block that we used the last time, the 1619, and seeing how much gap that we have gained. You can see that I have gained more gap on the medial side now. So I'm going to go to the next spacer block, which is going to be a 1719 block to see how much that we have. Now I'm using the how much gap that we have gained. So this is a 1719 block. And here I find that even now there's a little bit of opening on the medial side. So I would use the next block, which would be an 1819 block and see how the gaps are. So 18 on the medial side, 19 on the lateral side and see how the gaps after the tibial recut is. Now we'll find that both the gaps are very snug. So now we have come to 18 on the middle side and 19 on the middle side. In not all cases that you should aim for 1919, we'll tell you when you should not aim for 1919. So in this patient, I've left it at 18 on the medial side and 19 on the lateral side, just as how the robot would do. So the steps are common with the robotic platform. So we should know in which patients that we must stop short of achieving a full gap on the medial side. Just like the example that we showed, we have achieved only 18 on the medial side and 19 on the lateral side. Now these patients are the ones which show a lot of sclerosis on the X-ray on the tibia, like the example shown here. Sclerosis of the tibia, if seen on the X-ray, is indicative of presence of remodeled bone. The remodeled bone on the medial tibial condyle is the pathological structure in varus knee, causing tenting of the superficial MCL, leading to tightness, and it's not really a contracture of the superficial MCL. It is the tenting of bone due to remodeled tibia after you remove the osteophytes. So basically, this remodeled bone must come out. So after we place the tibial component, we would remove this, and this would establish now a balance of 19-19. We left 18 on the middle side, but after you remove the bone, it will become 19. If initially you went to 19-19 and then you remove this bone, you may end up more gap on the medial side, and that's a problem. Both in robotics as well as in factor methodology, this step is common. So you can see these three examples in which there is a lot of sclerosis on the tibia, indicative of remodeled bone, and therefore you can see during the surgery there is significant bone outside the tibial plate, and this has to be removed, and this will give you a balance, the final 1 millimeter of balance. And you can see in the post-op X-ray how the medial tibia has been shaped so that the remodeled bone has been taken away, and this will establish balance, and there's no need to do any release. We now go to step number 4, which is to achieve a native femoral rotation. This again is very straightforward when you use any robotic platform. All robotics platform will be able to display a coronal section of the distal femoral condyle, and then we can match the V shape of the trochlea to the V shape of the femoral component, and thereby we are able to dial in the native femoral rotation of the patient. Now, the same thing can be achieved with the factor methodology. However, there are certain things that we have to take into account before applying this. The following principles apply. In normal anatomy, the lateral cortex in the supracondylar region is higher than the medial cortex by approximately 5 millimeters. And if you are able to reproduce this 5 millimeters, you match the native rotation. Parallelism with the anterofemoral cortex is achieved by choosing the rotation that gives differential between lateral and medial side of approximately 5 millimeters in the supracondylar region. It is mandatory to have a jig where rotation can be altered as per patient anatomy. The commonest rotational shape match that we find is 1 degree external rotation, and our restricted boundary is between neutral 0 to 3 degrees of external rotation. And this is how we go about it. So this is a very standard femoral jig that we have in all our TCAR instrumentation. So the first thing I'm doing is I'm going to just pin this block in place. And then I'm going to look at the differential between the lateral and the medial side of the anterofemoral cortex in the supracondylar region. So here we can find that the differential now is closer to 10 millimeters. That means that there's too much external rotation presently, and therefore I need to reduce the external rotation to shape match the rotation of the femur. So I'm going to reduce the external rotation. Now I'm bringing the rotation to 1 degree of external rotation. I'm tightening it, and then I'm going to reassess the differential between the lateral and the medial side of the anterofemoral cortex. So now I'm looking back again, and then I'm seeing what the differential. Now the differential seems to be 5 millimeters, which is our aim. And now we have shape match our femoral rotation to the native femoral rotation. Now we always use post referencing, and we have pinned the block in place. Then we put a 4-in block and we proceed to cut as usual. Surgeons may wonder how we can suddenly use the anterior femoral cortex to dial in the native femoral rotation. It's nothing new and is well described in literature as the grand piano sign. There are many clinical, CT, and computer simulation studies, hundreds of them, that proves the validity of the grand piano sign, and they're using exactly the same. Now, if you cut the femur, even anywhere between 0 and 3 degrees, provided you match the native rotation to the patient, you will always consistently get the grand piano sign, as we can see in this example. In this example, the external rotation kept was 1 degree, but still we get a very good grand piano sign. We move on to step number 5 now, which is fine-tuning the posterior slope of the tibia. This is done very elegantly by any robotic platform. All robots will give you the flexion space even before you have made any bone cuts. So once we provisionally place the femur based on native anatomy, we can work out what the posterior space is, and then we can dial in the slope so as to match the posterior space to the extension space even before we have made any cut with any robotic device. We can do the same thing with the factor methodology as well, and this we call as space matching. So when we use any PS design, a middle pivot, or an ultra congruent design, we want to vary the slope between 1 and 5 degrees of posterior slope depending on the posterior laxity or the tightness. Now you must keep in mind that the PCL and the posterior slope are closely related in any knee. Now once you take the PCL off, then you need to space match the space to what is native for that patient. However, if you are retaining the PCL, then we can do a shape match. You can cut the tibia in the same slope. So if you're not doing PCL retaining design and you're taking the PCL off, we're doing space matching. And how we do that is we have to evaluate the flexion space based on what we call as the examination after exposure. And then if we find that the flexion space is lax, we give only 1 degree of slope. If it is standard, we give 3 degree of posterior slope. And if the flexion space is tight, we give 5 degree of slope. So once we assess the posterior slope, we space match that to the extension space. And this is how we do an examination and after exposure. So I expose the knee now. Now I'm looking for any laxity in extension. And then I'm looking for the patellofemoral tracking. And then I'm looking at the flexion space. And I want to quantify it either as lax, standard, or tight. Based on my reading, I would dial in either 1 degree posterior slope or 3 degree posterior slope or 5 degrees posterior slope. And now we are able to space match the flexion space as the extension space, just like how you do in a robotic platform. It's important to keep in mind that there are 3 flexion rules of FA philosophy for TKR in the less deformed knee. And this is true both for robotics as well as the factor methodology. Rule number 1, flexion rule, is that we have to space match the slope based on our assessment of the flexion space, and we vary it anywhere between 1 and 5 degrees for whatever design that takes off the PCL. If you have a PCL, then you have to shape match and dial in the same native slope. Rule number 2, we have to dial in the native femoral rotation, which we covered how we are able to do both in robotics as well as in the factor methodology. Flexion rule number 3 is that we must always use a posterior referencing because we need to have a measured resection, and once we use posterior referencing, we're taking off exactly the same amount of posterior condyles as what you would replace with our TKR component. So these 3 flexion rules are very important when you use FA philosophy in a less deformed knee. We now proceed to step number 6, which is the assessment of the final soft tissue balance. Now all knees will fall into balance straight away without the need for any release. This is known as pre-balance. This is very fascinating to see in robotic platforms. Now in all robots, we do only a virtual cut and then we look at the spaces and we proceed with only the cuts that give us the good balance. So therefore the knee is pre-balanced. The same thing can be seen even in the factor methodology. As we are following the same sequence of steps as in robotics, the knee will be pre-balanced even when you adopt the factor methodology, as you can see in this video. So I've not done any releases. We have come to trial reduction. I'm now putting in a 9 millimeter ultra congruent poly. And then when I bring the knee to full extension, you can see that it will come to full extension automatically. There is no release required. And the medial and the lateral space will consistently be balanced. It's very important that in FA philosophy that the extension medial space must equal the lateral space. Absolutely snug, full extension we have. And when you go to flexion, you must have that sort of ideal laxity, not too tight, not too loose as well. So the knee is certainly pre-balanced here. So we have to know when is pre-balance not possible and soft tissue release required. There are three special situations as we discussed earlier, and these must be detected pre-op. One must not wait till the end of surgery to find out that you need release. This is true for both robotics as well as factor methodology. The three special situations are: number one, the white tiger CPAKs. When you have gross bowing of the femur, it's important that you do some releases. Otherwise, you'll find that your hip knee ankle axis is very extreme. Second thing is when you have a very low MPTA, when the MPTA is 84 or lower, then we find that if you are trying to go as per native anatomy, you will get a very oblique joint line, and this will be outside our restricted boundary and not a good idea. The third situation is when you see gross lateral laxity. This typically we see on a one leg standing film, and it doesn't make sense to take care of the laxity by doing bone cuts. So one has to release the medial side to equalize the lateral side. So in these three special situations, uh, one must not attempt a pre-balance. So we typically would do a superficial MCL pie crusting in these three special situations, and this is how we go about it. So we come to trial reduction. So now I'm inserting the 9 millimeter poly inside. And once when I extend, I'll find that because the medial side is still tight, we're not able to fully extend the knee. That's very typical of one side being tight. So we hold the knee in this position and then we use a 16 gauge needle and pie crust the superficial MCL. It's very safe to do with the trials in place, as the lateral side will act like a check and one cannot over release. So I'm pie crusting the superficial MCL, as you can see. Typically you'll have a crunchy feeling and then you are able to extend the knee fully. And now you can find the knee is extremely stable. It's rock solid both medially and laterally in extension, which is our aim. And now we look at the balance. So in extension, there is no opening either medially or laterally. When we come to flexion with the patella in place, the knee must be solid, very snug, as you will see now. It's absolutely snug. However, when the patella is subluxed, there must be some laxity. That is what we want to aim for. Now, when we look at the balance in flexion, typically we'll find that as we have reproduced the anatomic parameters, it is about a millimeter or two lax laterally than medially. And this we have a sort of medial pivoting. You can see the medial pivoting acting. So when we reproduce the native parameters, you'll always find that the inflection, it's about a millimeter or two lax. However, in extension, it's very snug and equal both medially and laterally. We all know that the patients will be unhappy if they have a residual FFD after TKR and they don't achieve full extension. It's not uncommon, and it's particularly a problem for less experienced surgeons. So we have developed this test in our institute to ensure that you got full extension after TKR. And this is how we ensure that it's got full extension. So now we take out the tibial plate and just put only the poly inside. The tibial plate in this system, Smith and Nephew, has got a 3 mm thickness. So once I come to extension, I have to demonstrate a 3 mm gap both on the medial and the lateral side. That means I have achieved full extension. Especially if the patient is obese, just looking at the limb may not be sufficient to tell that you have achieved full extension. You must demonstrate 3 mm gap both medially and laterally. Then we know that you have achieved full extension. This is a very useful test, and we'll make sure that we get this test is positive in all our patients, and none of our patients have any residual FFD and they achieve full extension. We have now shown in detail how one can adopt an FA philosophy and retain the CPAK type consistently in all patients with both robotics and factor methodology. You can see some examples here. The pre-op CPAK has been consistently reproduced post-surgery, and all these patients are well balanced in extension. They have equal space medially and laterally. You can see further examples of the same, and we have done hundreds and hundreds of these. The only thing remaining to do is to find out what happens to the HKA axis when you adopt an FA philosophy and retain the CPAK type. The first thing to remember is that any alternative alignment is never done in a grossly deranged knee like this, and only all the alternative alignment principles applies only to the less deranged knee as shown in this example. Now, it's been well documented that the HK axis is within 4 degrees of neutral in functional alignment or functional alignment philosophy, provided the restrictive boundaries are very conservative. So in the example you can see here, this is a valgoid distal femur based on the abridged CPAK. That is a joint line with the distal line obliquity which is greater than 3 degrees, and that's the post-op X-ray. And we find that the same pre-op CPAK has been reproduced. And when you look at the HK axis, it's 3 degrees. So if your restrictive boundaries are conservative, your HK axis will always be within 4 degrees. So that means we must define what are the restrictive boundaries. So this is known as the conventional conservative restrictive boundaries, and these are the distal femoral valgus must be within 3 to 5 degrees. The proximal tibial cut varus cut must be from neutral to 3 degrees. The posterior slope of the tibia must be within 1 to 5 degrees. The femoral rotation is within 0 to 3 degrees of external rotation. The extension space must be fully balanced medially and laterally. The flexion space is usually 1 to 2 millimeters lateral laxity. Now, if you adopt these conventional conservative restrictive boundaries, we find that the HK axis is guaranteed to be within 4 degrees. It's now very obvious that one can adopt an FA philosophy and retain the CPAK type consistently with both robotics and factor methodology. The time has now come to see whether there's any advantage of one method over the other. Now, does robots have any advantage over factor methodology? The answer is yes. Using robots, we can actually dial in the flexion of the femoral component and thereby adjust space. This part of the sagittal balance, although we do a sagittal balance in factor methodology as well, we're not able to flex the femoral component to adjust balance. So in that aspect, the robotics does score over factor methodology. The other advantage of the robotics is that if your restrictive boundaries can be far more extreme when you use robotics, whereas you have to be very conventional and conservative when we use factor methodology. Now, does the factor methodology score over robot in any way? Yes, it does. It's a very important advantage it has is that the factor methodology is not implant specific, and one can use it with any TCAR, what you have been using so far. You can continue to do the same using factor methodology. Whereas all robots are married to specific implants and you cannot use any other implant. This is the major advantage of the factor methodology. We thank you sincerely for listening to the talk. We hope that you'd find this very useful. If there are any comments or suggestions, please do write to us and we'd love to hear from you. Thank you.